It is truly an honor to be here. It's unbelievable the kind of work that you're doing, and that is really kind of a groundswell. So I'm truly honored to be with you today, and I will be provocative, more than likely. One of my disclaimers is that I'm no longer attached to an institution, so the ideas are mine and mine alone, and therefore I will voice them. Second of all, whenever I speak to such a talented group of faculty and students, I'm always worried that I don't really have an original thought. But since I've gotten to know who Kirby Ferguson is, I feel better about that. Does anybody know who Kirby Ferguson is? Well, he actually is a filmmaker and a writer, and his thought is that there is nothing original in the world, that the way we are creative is that we remix. So he calls everything a remix. And if you were to talk to him or listen to him talk, he would talk about much of the music and follow this theme through, much of the art, much of the big ideas. And his thought is that the only original thing in the world is the Big Bang. So that makes me feel a lot better about what I'm about to say. So I'd like to start with this diagram, which is a diagram that I've made up that kind of looks at our healthcare needs from a population perspective. And if we were to look at this, this is my one and only slide, okay, we would see that we all need to have clean water and air, sanitation, and food, right? That's our public health needs, right? And then we need to have some kind of way to keep us healthy. And that is our health maintenance, our prevention, and we need to care for ourselves with episodic illnesses. Now, most of the time, episodic illnesses will get better on their own. But we need healthcare providers to keep us from getting sicker with those and to not just mess us up, right? Because 80% of our illnesses get better. And then about 50% of us will end up with a chronic disease. Sometimes that is something like hypertension. Other times it is complex, like something like lupus. And that often advances to complex disease, where we end up with more than one chronic disease or more than one organ that is problematic. And finally, at the top of the pyramid, we have truly high-intensity illness, where we are critically ill, require lots of input from the healthcare system, and actually where we usually see all our patients in an academic health center, which is in a hospital, right? And if you were to look at this, you would see that this pyramid actually has a good correlation with the cost of our healthcare system. So at the very top, we see that 5% of that population actually incurs 50% of the cost. Or at the bottom, 50% of the population is only utilizing 3% of the cost. And in between, it's like a 50-50 deal, right? So if we were to think about this, well, how do we go up and down that pyramid, or how do we traverse that, right? We know about the modifiers that help us move one way or the other. Certainly the social determinants of health, right? That community that we're born into, or that zip code, or that mores that come from our family, and our socioeconomic status, right, contribute about 15% to the variability in this diagram. And then behavior, right? 40% of what makes us sick may be related to our behavior, whether that's obesity or tobacco or not wearing seatbelts. Finally, if we're lucky enough to live long enough, we will get sicker. And 50% of that healthcare dollar ends up going to people over the age of 65. So therefore, caring for an aging population is a great thing because we're allowed to age, right? But it's expensive. And then, of course, there's our genes, right? 30% of variability is thought to be due to which genes we get or don't get. And maybe over time we'll be able to modify that. But right now, that's a little bit like the following: luck, right? So that's how we can move up and down this pyramid. And then we might very well say, well, what helps us move up and down? Is it possible to move up and down? And what I would hypothesize is that we spend all of our time at the top where we're looking to modify that. But there are reasons that that's really tough to do. And that is that when I think about it, think about where all the advances are. Right? I was just recently in an electrophysiology lab, which I hadn't been in for years, since I'd been sitting in a provost's office for a while. And I was shocked to see that to manage one patient, there were 10 individuals in 1,200 square feet with GPS mapping, 7 screens, and ultrasound that was intracoronary, and 2 physicians out of the 10, right? 3 nurses. But guess what? 5 other very intense, technically trained individuals who were looking for that one spot to zap and that one patient that would stop him from having sudden death. Well, when you think about it, that is really expensive, is really at the cutting edge, but that in the long run will end up making a better life for somebody who will not die. And when we think about it, that is where a lot of our cost is technology and advancing the envelope. The other reason that it's hard to change is that when people have looked at this, the top 1% that incurs 20% of that cost, right, stays there. So they don't easily come back the other way. They stay at that high-risk area. And finally, all those things like social determinants. We've worked really hard, and we have a really hard time in our society impacting that. So yes, we focus on the top, but more importantly, maybe we need to think differently about how to prevent us from getting to the top. And if one were to look at this in this context, this pyramid of healthcare needs, can we not relate that to how we have educated over time? And I think you can see from this bar, it's not how we think about it necessarily. We think about everybody going along their trajectory. But the reality is that as we move toward the top, which is really, again, our healthcare, how we get our healthcare only contributes about 10% to our wellness, right? But we have increasing specialization, but also increasing time in training. So I want to use this diagram to ask 3 questions and think through this a little bit. Number 1, what does the public expect from us? I'm going to try to answer this not so much in the competencies that we need to have. That's true, the empathy, the compassion, the communication, et cetera, but more in terms, what does the public understand their healthcare needs are? You know, in 1978, we began to use for the first time the term primary care, because WHO defined primary care as getting technically proficient, accessible care in your community. Now, after that, we in the United States defined that as physician-directed. Right? And by 2001, we'd actually talked about the idea that it needed to be patient-centered care when the IOM talked about patient-centered care. What does that mean? That means that patients and physicians and their families would work collaboratively to come up with decisions that were appropriate for the patient. And even as recently as 2007, right, when we talk about the patient-centered home, we talk about it as being physician-driven. Now, it's interesting that Barbara Starfield, a big proponent and leader of primary care, right, now talks about maybe what we really need is patient-focused care, or person-focused care, rather. And what this means is not the terminology that we use of patient-focused. She says that's become more about visits in the clinic and capturing visits, rather than the person and the holistic approach to their illness over time and integrating all the episodes of care in their lives. That said, then, what do patients understand of how we deliver this care? Now, the AMA did a truth in advertising campaign, bless their hearts. And if you look at the data from this campaign, it's very interesting to see what patients or consumers understand of us, right? When you ask who is a medical doctor, they can get the surgeon part, the orthopedic surgeon part right, 90% of the time, along with OBGYN and family medicine. That's in the 90% level. That 60 to 70%, it's dentists, they understand as doctors, okay, anesthesiologists, and psychiatrists. At the 30% level, they call otolaryngologist doctors and doctors of nursing practice. So clearly, the public is confused in who we are and what we do. And I could add the other 18 professions in there somewhere, and you would understand audiology, podiatry, et cetera, all confusing. So when you ask the public, what do they want? They want to understand that we are competent to do the work that we do, and they want to understand what is that work that we're supposed to provide. Do they care about the name? I would guess no. They care about competence. So then what is our responsibility? Our responsibility is to make sure that whatever we're doing, we are creating a competent healthcare provider. And our competency, yes, now we've been great since the ACGME and the ABMS started with the word competencies, and actually many of our professions, other professions, were ahead of us in that regard, especially things like public health and pharmacy, right? We've started to use the word competency, but we haven't really moved in that direction in such a way that allows us to think outside the box. We still measure our graduates in terms of time in, right? And that is truly a challenge because a degree does not beget competence. The more we look at this, we know that practice and experience and volume always create better outcomes than just the background. So it behooves us to assure that our patients, that our trainees are actually competent. Now, the next question I'd like to ask about this diagram, or referring back to this diagram, has to do with our cultural barriers, something that we speak a lot about. Before I get started, I want to see in the audience who are students? And the rest are faculty? Okay. When we think about the tradition of our professions, right, we really understand that we have unique cultures, cultures that we pass down from one generation to the next. Now, it's interesting that the concept of professions grew up after the Industrial Revolution as a kind of a way to control our market, right? So professions had unique knowledge that they controlled and they had the purview over, and they actually defined entry into. So you add that to the culture, and you begin to understand where we came from. I'm going to mention a few professions that I've worked with And just to give you an idea of how this may influence some of the barriers that we face as we try to create new kinds of systems to educate the workforce of tomorrow. So medicine and dentistry were a little bit in parallel, right? So in the early years prior to the Industrial Revolution, right, healthcare was provided by women to neighbors and families. After the Industrial Revolution, right, when it became market-driven, England put an exam in place for physicians. And it wasn't that women couldn't take the exam, right? It was that women didn't have they couldn't be admitted to the university. So therefore, they couldn't take the exam. So that became the intrinsic bias of a guild profession, controlling its entry and denying access to other groups. And this is pretty similar for dentistry, although I have to say that University of Michigan graduated the first African-American woman from dentistry in 1890. But in the 70s, we were still at 70% women. And that actually has colored both our gender and our social biases of our professions. Women were believed more appropriately, both in dentistry, where they advertised for ladies in waiting as dental hygienists to help dentists, right? Nurses in the hospital to help doctors do their work, right? Nursing became a profession that was more appropriate for the other gender. So because of that, we developed kinds of cultures that were really hierarchical in nature, because that was the tune of the time. I have to say that thanks to my experience at OHSU, I had the opportunity to serve as Dean of Nursing. And your Dean of Nursing and another Dean of Nursing helped me to understand the differences in the cultures and why nursing and medicine actually have such a totally different culture that continues to be propagated and takes a lot of work to bring back together. And that is, nursing was a hospital-based culture meant to serve physicians, and we're at the bedside. We all know that it's the nurses who really care for the patients, right? But the reality was, when they wanted to become an academic discipline, they developed in a university, right? And much more as an academic entity separate from the academic health centers. So when we go to do things like working together or working across educational programs, those are truly two divergent cultures where nursing has had to grow an academic base and therefore has worked differently in our academic health centers. What about pharmacy? I actually view pharmacy as one of the most progressive of the professions. Actually, he started as chemists for many years, worked as chemists, right? But in the 90s, began to understand that medicine has changed so much that they needed to have much more clinical training, and actually integrated by the mid-90s into clinical enterprises, and actually have been amazingly progressive in the work that they do, especially leading the way in many instances in interprofessional education. Well, what about another program, physician's assistants? I mention that because their evolution is particularly novel and may give us insight into things that we can do in the future. The PAs were started by a surgeon at Duke, Eugene Stead, who noticed that you could go through medical school in a very short time when the need is there. And that is that post-World War II, rushing doctors through, you could actually finish in a couple of years. So we said, what about if we try to expand our workforce by training PAs, and began with first 4 MedXs in 1966. Well, now all those years later, we now have over 100,000 graduates of PA programs and over 160 PA programs. Now, what does this all mean for us? Where are we headed, and why do I mention this? Well, as these professions have pushed their profession to care for patients, a really important thing, that's why we're here, right? We begin to have boundary issues, right? Physicians have always controlled how they practice, right? And over half the states in the United States, advanced practice nurses can practice independently. PAs have prescription writing ability in all 50 states. And now pharmacy, thank heavens, is also being granted some prescription rights to increase access. So these kinds of activities in our culture, where in some cultures we're very hierarchical and independent and rely on data, I think you can guess which culture that is, and others where we value collaboration and relationships, you could probably guess that one too, right? We are now coming into a time where we are looking at the boundaries of our profession. And what I would say is that when we look at this diagram, we do not feel that stress at the top of the pyramid. All of us recognize that when somebody is very sick, we come together, we rely on all the disciplines to help us, right? And many times we would not made the progress we've made without the multitude of disciplines that have created that, right? In my own world is bone marrow transplant. When I trained, it had about a 10% survival rate, right? It was not the physicians who changed that survival rate. It was the dietitians, right? The pharmacists, right? And most importantly, the nurses. Without that collaborative, creative environment, all with the complex patient, we would not have made that impact. Now, can we be better at teams? Yes. Do we need to communicate better? Do we need to learn new science on health systems? Yes. Do we need to do those things at the top of the pyramid? Yes. But we do a pretty good job of figuring out how to work together in crisis mode or when we need to. I maintain that the big issue is right here. This is where we come into conflict. And this is where we should try to think differently. I want to actually mention an exercise that we went through to try to figure out where we as professions all fit in this realm. And the exercise went like this. We wanted to look at all of our accreditation standards and our graduation competencies and begin to map where the overlap was. Well, I would dare say this took us a year of meeting every single week. We had to agree on what the language was, do a qualitative analysis, but in the end, we were able to figure out that we have very, very many similarities in our accreditation standards for our 8 largest programs, that they fall into medicine, nursing, dentistry, and PA, and our nutrition program, and actually some of our public health programs. So we were able to say, gee, we have similarities in accreditation standards, right? And then guess what? If we mapped all of our graduation outcomes, we actually said, wow, we have a lot of similarities. In fact, we could identify 13 overlapping areas that we were all doing together. I'm sorry, not doing together. We were all doing separately, but the same content. So what I would say to you is, if these are overlapping areas, and if our role is to guarantee competence, how is it that we shouldn't have a group of individuals who come out to the public who have this same knowledge base and the same skill set? How do we go about talking about that? And is it important? Do we really need 7 years of training for some, 2 to 3 years for other, when on the outcome side we can't see any outcomes. Now, back to this issue of our silos and our cultural barriers. I personally believe that IPE has done a humongous job of trying to help us understand and become familiar with other professions. If you look at the outcomes from IPE courses, students will readily say that. They will continually say, I now understand what other professions do. I think the biggest thing in many respects is that we have educated now a faculty to come out of their silos and understand what other professions do. And that is a huge leap. That may be the biggest leap because it helps us educate our faculty in the new sciences and helps us bring together in that direction. But I would ask you, is that enough? Is that where we want to go in the future? Which is, how is it that we are going to create a public expectation of practitioners that has such differences in their base? So to me, that is kind of the controversial question that is worth asking from the public standpoint and from our traditional educational standpoint. Again, calling ourselves years to X. I was struck that recently I just saw the University of Colorado's PA program going from 2 years to 3 years and then adding an additional year for a track. That sounds like 4 years to me, right? And I would actually have to say, you know, do we really know that we need 7 years to create the same outcome on another track? And I would actually say for an advanced practice nurse or a DMP nurse, who usually starts out way ahead of our medical students, right? How is it that they don't have the same training and requirements that some of our primary care trainees do? And what is the evidence that we should or should not have that additional training? So to me, it's taking care of this population that is where our boundary stress is in our professions and where we should ask some critical questions about what the future might look like for this. So I'm enormously impressed that the grassroots efforts of students will tackle many of these huge problems. But how might we consider moving forward in the IPE world? Is it about classroom education where we learn from each other? That's great depending on the level of the students. But is it going to create the impact that we want? And is it going to create the stickiness and the reward for us as medical practitioners of the future, allowing us to practice at the top of our license? So I just want to talk a little bit about potential ways to move forward. One is, I believe that it is critically important to try to have us go where the problems are the toughest or the need is the greatest. It's kind of like The Innovator's Dilemma, which is Clayton Christensen's first book about disruptive innovation, right? When you go to low resource areas or areas where the traditional ways of doing things don't work, you create innovation and you create cross-fertilization. So rural, terrible problem for the United States, right? And when you think about it, rural healthcare is different than what we see in the academic health environment. That's just one example. I've seen all sorts of examples out in the hallway of students taking on provocative projects, Meals on Wheels, et cetera, in areas of need. But in a rural community, you can innovate, right? You can have dentists do vaccinations and do health screenings because we need them, and where there's a dentist, It's equivalent to a healthcare provider, right? We can have advanced practice nurses be in the schools doing dental exams, right? We can use EMTs to retrain and do home visits when they're not doing emergencies. We can do e-pharmacy to make sure that everybody has access to pharmacists overnight when they become ill in an urgent care center. So there's ways to innovate, and by innovating in areas of need where the problems are great, usually many of these modifiers, especially in geriatrics, I would say, I think that that's where we are going to make the impact of what we do interprofessionally. We know that that is going to be a different approach to this issue than trying to break down many of the traditional barriers in our academic health center, which actually, remember, is only a very small % of the population. The next thought I had was that we need to go where the problems are new and novel. We know this in science, right? When you think about science, science has gotten away from the traditional, this is pharmacology, this is biochemistry, et cetera, et cetera. They focus much more on all the disciplines at all levels that we need to solve a problem. Well, there are new problems in medicine that require all of us from different professional standpoints to try to solve. I'll give you an example of one. The electronic health record, right? Right? The electronic health record, you're probably thinking about the fact that, oh, it's added, 2 hours of extra work for every day, et cetera, et cetera. But one of the biggest problems is that we all use it differently. Every single one of our professions views that medical record from a different screen. And that actually ends up with a high error rate. That's been shown from a number of standpoints, but most recently, I'd actually say the JCHO is starting to notice that. Well, how do you fix that problem, right? You can't have, in the intensive care unit, a nurse looking at one screen, a doctor looking at another screen, a social worker looking at another screen. You have to, in some way, figure out how we are all going to communicate to prevent errors. That's a big interprofessional problem, right? So solving newer problems through the professions and through our students, actually, that are the most talented, I think is another opportunity that we cannot afford to lose. And finally, I do think it's important to always ask why. Why are we doing things the way we do it? Is it just our tradition, or is there some evidence for it? I would say much of our silos, I believe, will get better because our students are different, right? While we will have the professional hierarchies that go on, our students in this generation are team-based, they're collaborative, they care more about the community and doing good, right? And so they will help drive this. But it is critically important that we as faculty think always about what is the opportunity I might have to ask that question? What resource do I have that maybe can be applied to everywhere else? What problem or what course do I want to have that everybody needs? I mean, health systems, that's a course, right? The health maintenance, shouldn't everybody know about health maintenance and adequate prescriptions for exercise? So that we begin to speak the same language. And I would just say that you at the University of Michigan have led repeatedly. I am totally inspired by the work you have done and you are continuing to do. And I would actually look for your leadership in the future in this realm. Yes, the buildings are siloed. We can't change the buildings. We can't change where we walk on campus. If we had to do over again, we might do differently. But we can change many of the other aspects of where we're headed. and think critically about what do we need to modify this diagram and to care for the largest population. And does it always have to be the way it was? As Yogi Berra always has said, right? The future isn't what it used to be. So thank you very much. And I would love to have a Bhagavad comment.
Well, we have time for questions. We have mics on either side. If anybody has a specific question that they can ask. Fortunately, we have plenty of time to have some very interesting discussions. So, you can go to the mic, Joe. And please introduce yourself so we know what discipline you're representing.
Good morning. Joe Kolars, Dr. Mladenovic, outstanding talk. Really appreciate your wisdom as always. My question pertains to where do you think the disruption will come from? I'm so impressed that our students and learners come in with this kind of thinking. But then in order for them to advance, they have to become part of their professional associations. And then their professional associations really hammer home, it's our identity. We are here to advance our tribe. And there's so much energy that goes into self-preservation about promoting the tribe. And that seems to be where most of the power and the energy base is. So is it trying to get, and I see the tribes coming together sometimes to give lip service to these concepts, but at the end of the day, everyone goes back to their own bunkers. So do you think that the change will come at trying to get more togetherness there? Or do we need to start to cultivate our learners to create something different, where the primary center of gravity isn't self-perpetuation of these identities they're inheriting, but to create something new?
Impressive question, Dr. Kolars. So let me make just a few comments about what I think will push us to change. There are these external forces and exigencies that usually do that, right? I think that clearly if we head in the direction of value-based care, that promotes some change, right? Because there are too many people that need to be involved in value-based care. And yes, the guild is there, but we need a broader workforce doing different kinds of things to move us forward. So I think there's that. I think the movement of medical knowledge actually is going to change us so much. I think if Jim and I were just mentioning, right? I do believe that things like deep learning is going to change radiology, if it's even going to be there. Right? So there are specialties that are going to change the way we practice and are going to distribute our ability to do those things. As many of you know, one of my hobbies is point-of-care ultrasound, changing the way we evaluate a patient at the bedside, right? Physical exam is about a 50-50 guessing game. And so can we improve that by point-of-care ultrasound? Well, once point-of-care ultrasound is available, right, and there's deep learning, you can imagine that patients are going to slap that on their chest, right? And they're going to tell it into somebody, and somebody's going to say, oh, come in, you've got a heart attack, right? And so technology and deep learning, right, is going to change a lot of what we can or can't do. You know, it's interesting to me that I just saw a couple of comments. I mentioned the dentists giving vaccines because we already had our students doing that, but Arthur Kaplan, a bioethicist, was questioning physicians about whether they thought dentists should give vaccines. And I thought, wow, that's an interesting question, right? cares? We need to get to as many patients as possible. And right after that, there was a whole blog about a student who graduated with an MD and hadn't gotten a graduate medical education slot, and now was going back to nursing school. Right? Now, I dare say that's going to be an amazing individual when she finishes. But the reality is that really where we're headed? So I think there are external pressures that are going to drive some of what we need to do. But I do believe that our students are also going to drive us. When you look at the new world, the students are, every generation has changed. When we were students, they probably looked at us and said, oh my gosh, now we say we're into the 80-hour rule, how horrible is that? It's probably the best thing that ever happened to us, right? But the reality is, I do believe there are going to be external pressures. I do believe, you just look around what the students have done. And my campus for rural health, which is a distributed total interprofessional campus, I can't call it my campus anymore since I'm not at OHSU, but one of their tasks was interprofessionally, not only did they live together and practice together, right, with their preceptors, but they had to go to the community, work with the community to identify a big problem, right? And we supported them with health community workers, with health service researchers, and they had to actually work on that problem together. And through that, we really saw students innovate to come up with novel solutions to community problems. And quite honestly, the professions that took the lead were not the ones you would have expected. And yet, when you see the outcomes and the evaluation of that experience, the students felt it. And the students feeling it at a sticky level is very different than when they come in and they're learning about each other, from each other, because they don't have a lot to teach each other then. But as they advance up, I do believe that our students will drive this if we let them. And then there'll be external pressures that will force us to change. It would be nice if we could think about changing before then.
Raj.
Dr. Mladenovic, thank you for provoking us to think differently and to continue to be better. I wonder, do you envision that in the future all learners who will eventually become part of the caregiving team will still go through universities or some sort of learning organization? And if so, how do these organizations need to dramatically be different to be able to accommodate the sort of change in healthcare that is already in front of us, to help support and develop the students who are already inclined to be different to truly stay different? And if not, what other mechanisms for training and education do you think will exist?
Ooh, big question. And, again, I think if you look at other healthcare systems, and again, I was struck that when I had my campus in Southeast Asia, when we went to Myanmar to work with a program in the Monk's Hospital, actually, it was striking to see how they could do 150 eye cases a day with one surgeon in an environment that we didn't understand, and that they could train the community to do the follow-up of these cataract procedures, right? And their outcomes were as good as ours. It was striking. So I do believe that there is a role for new kinds of, I don't want to say jobs, but new kinds of support individuals that will expand our ability to give health care. And it is not just our purview in our own professions that will allow us to be better. As to the issue of the universities, I dare say that we are going to be in a university setting for a long time. And I quite honestly can't envision us not doing that for a lot of different reasons. You know, in a university setting, because of the advancement of knowledge, you've got to think that that's where much of the advance will still come, even though we need experiences and communities to work in. What are other places for training or education? I think large health systems, clearly, that are not university-based. Community-based, I cannot tell you how much I've learned through working with my rural communities and their ACOs, accountable care organizations, where people really do look at the population level. You know, I think we've given lip service to the concept of public health and population health in many of our professions, not public health, of course, but in the others, and that we haven't learned the basics of population health, and that we need to engage in that kind of work somewhere. We know lots of things make a difference in what's stickiness, right? And what our graduates end up doing. So I think it's important that we end up having those experiences. So for instance, we know that if people work and train in public hospitals, right, they go on to give more indigent care, right? And to understand the social determinants of health better. Well, what kinds of other experiences are important so that we don't only train within the university? You know, I think the other aspect that we should ask ourselves is, will we need a different kind of caregiver? Do we really have to focus on the name of that caregiver or just the skill set? I don't know the answer to that, but I can imagine that there are individuals who are going to be skilled at working in home, much more working in home care or with the geriatric population that we've kind of left by the wayside. And so I think that as we look at the future, training within an academic health center as opposed to training in our community is not, we shouldn't just be isolated in that regard. Because I think a lot of our cultural issues come because we work in these high intensity environments, not because we work where we're going to end up working. And so I don't know if I answered that. I don't know where you are. I don't know if I answered that question. I guess I'm still too traditional to think about leaving a university.
Any other questions?
Hello. Łukasz Przychodzin here, pharmacy informatics resident at the hospital. So I'm going to take your two answers that you gave regarding deep learning and your involvement in the community in Myanmar and bring you to the question of, do you see disruptive learning with that area of conflict with non-complex chronic diseases and health maintenance involving the community more in their own care as compared to putting the conflict within healthcare professionals?
Absolutely. And if I were really spilling the beans, okay, what I would say is much of this can be done by a patient themselves, right? Or not a patient, an individual, right? With all the tools that we have available, right? You could imagine where a healthcare provider is only going to need to be involved when something goes wrong. And really not the entire time. There's in full disclosure, there's a diagram like this. It's a pyramid, and it's constructed by Tom Friedman, who's head of the CDC. And it is about the public health approach to change. And at the top of his diagram is counseling and education, because he says that has the least impact. Right? So in many instances for wellness care, that's why we say individuals have to see a provider, right? So the answer to you is I do believe that much of this will be done on its own. When I give this talk about point-of-care ultrasound, I often show an individual from Intel who now heads the president's task force on technology, right? And he actually talks about his kidney transplant and how as a student at Stanford, he got very ill and has had this long disease. And he actually, on stage, if you were to Google him, you would actually see that he puts a point-of-care ultrasound on himself, on his kidney, calls his doctor and says, yeah, is my cyst getting bigger or smaller? I won't be able to come in for a few months. Let me know what I have to do, right? And he manages his care like that. So you could imagine that, especially in rural areas, that patients will need to take responsibility. We'll need to figure out how to do things differently, and that will then permeate, and we've seen that everywhere.
I have one ending question, which you've already dealt with, and it's a loaded one, as you might guess. I was at a conference at the National Academy of Medicine that was entitled The Financing of Healthcare. And we had economists from the World Bank, and they basically said, we can't afford to spend more money on healthcare than we are now. It's just going to take away from other resources. Well, that implies we're going to have to do something. Now, you were in the position of actually making those decisions while you're there. What's your advice to people within the health profession of how they're going to be able to have to change? Because they can't all expand. They're going to have to do something. So what's your thoughts on that?
So there are a couple of things that we know. Every time we educate more doctors, it gets more expensive, right? Every time we get more specialist care, it gets more expensive without better outcomes. So I think we are going to have to change from that realm. And then we're going to have to figure out what the top of everybody's license is, actually, and let them do that work and do it well. And figure out that, quite honestly, if you went to 4 years of dental school and have the same basic science as somebody else, it's not hard to cross-train with some other clinical skills to kind of distribute our healthcare better, which is still the problem, right? So I would say that those are the tough decisions that I see. They're very contrary to what we say in the public. So I think, the campaigns about using healthcare wisely, the testing that we do, looking at those costs, focusing on the aging population so we don't spend the most in the last 6 months of care. I mean, there's lots of work to do to cut down the cost of our healthcare. And I would also say, while we're doing that, we have to cut down the cost of a healthcare degree for our students.
Okay, let's thank her for such a provocative.